Hello, Bay Area. You're listening to Radio Mirchi 3010 AM. This is your one and only RJ Mirchita. And as promised, today I'm very, very excited because today's show is COVID awareness. Show day 51. એટલે કે I think ગુજરાતીમાં 51મો show છે, which is very, very lucky. And today I have a very, very special doctor from Leelavati Hospital, Mumbai, who is cardiologist, and her name is Dr. Falguni Thanki, and she will be talking to us about cardiology and COVID, and she is a great doctor. અને એમના પર તો હું ઇન્ટ્રોડક્શન આપીશ ત્યારે બોલીશ, but I want to start this show today with a very common complaint, right? જે બધા હાર્ટ પેશન્ટ્સ આપણને કહેતા હોય છે, નહીં? મોસ્ટ કોમન કમ્પ્લેન ઇન્ક્લુડિંગ માય સેલ્ફ ઇઝ લાઈક મને ખોટું લાગી ગયું. અને ઇંગ્લિશમાં ટ્રાન્સલેશન શું છે એનું? આપણે એવું કહીએ કે ડીડ યુ માઇન્ડ, ડુ યુ માઇન્ડ? કેટલું યુનિક છે, નહીં? ખોટું લાગવું આમ ઇફેક્ટ તમારા હાર્ટને થાય છે, બટ તમે એવું પૂછો છો કે ડુ યુ માઇન્ડ. એટલે ઇટ્સ વેરી કોન્ટ્રાડિક્ટિંગ, બરાબર? અને બધા પેશન્ટ્સ એવું જ કહે છે કે આમ ફેમિલી કંઈ પણ ઇસ્યુ થઈ જાય, કોઈ તમારું આમ ઇમોશનલ બ્રેકડાઉન તમને થઈ જાય છે, then you get all these cardiac problems, right? You don't know the reasoning behind it, but the root cause would be, you deteriorate time by time. So this is the complaint, do you mind? So this is what I wanted to start the show with. We ask people all the time, do you mind? But there is no point of asking that because they obviously mind. People will judge, they will mind, they will have this kind of heartbreaks, and they will have heart pains. But that's why we have amazing cardio doctors who are always there and who advise us to stay fit. They advise us to be on track. They advise us to eat healthy. And today's show, we are absolutely going to discuss about after COVID and before COVID. The life is very, very different. So what actually happens? What is the basics? What is under the hood in your body, inside your heart? So there are many such things that I'm going to talk about. And we also have our Dr. Modha, founder of Gokul Group of Hospitals. And આપણે એમની પણ advice લઈશું કે ભાઈ, what happens actually in a cardiac patient who undergoes through COVID, and what happens after COVID? What kind of procedures are there? Which procedure would make sense? Which would not make sense, right? Sometimes cardiac patients are always there like, okay, આ procedure કરાવી કે આ કરાવી, right? Doctor, multiple consultations, and it's always like એક ડોક્ટર બતાવો, બીજાને બતાવો. But guys, calm down, relax. એ જ આપણે ડિસ્કસ કરશું આજે શોમાં. And so this is all the things that I'm talking about, a little bit on the funny side. But without taking further ado, I want to introduce first Dr. Falguni Thanki. She has done her MBBS, MD in General Medicine and DNB in Cardiology. Dr. Falguni graduated with MBBS from Sri MP Shah Medical College, Jamnagar in the year 2000. MD General Medicine from Sri MP Shah Medical College, Jamnagar. She has done her DNB in Cardiology from Leelavati Hospital and Research Center, Mumbai. She has more than 3 years of PG training in General Med, worked as a senior registrar in General Medicine and intensive care, and has completed more than 3 years of super specialty training in clinical, non-interventional and interventional cardiology. She has worked at various hospitals, including, એટલા બધા names છે ને કે તમે વિચારશો કે ઓહો આટલો બધો experience. So she has worked at MP Shah Medical College, Jamnagar, yes. So she also did her MD postgraduate training from 2004 to 2007. She worked as full-time physician at Heartkesh Healthcare Foundation in Junagadh, Gujarat. She also worked as a full-time physician at Seventh Day Adventist Hospital, Uttapam, Palakkad, Kerala. Kerala is very beautiful. What do I say? Land of elephants. એટલે ત્યાંનો પણ એમને experience છે. She did her worked as a cardiac ICU registrar at Atukal Devi Institute of Medical Science, Thiruvananthapuram, Kerala again. Consultant at Nanavati Hospital, Junagadh, Gujarat. Plus worked as assistant professor at Department of Medicine at Pramukh Swami Medical College, Karamsad from 2014 to 2016. And then she worked for 3 years in Department of Cardiology at most famous hospital. તમને ખબર છે અમિતાભ બચ્ચન જ્યાં જાય છે ને, આ એ વાળી હોસ્પિટલ છે, સેલિબ હોસ્પિટલ. So she worked at Leelavati. She worked for 3 years at Leelavati Hospital in Department of Cardiology and Research Center, Leelavati Hospital and Research Center in Mumbai during her DNB super specialty training from 2016 to 2019, and currently she is working as associate cardiologist at Leelavati Hospital. હવે all the time I tell you, if I introduce any doctor on this show, probably I need to write a book. But I'll try to form this very shortly, which is she has also attended several and various conferences of national and international repute. Some of them are API Con India, Live, BICI, and also completed various workshops on non interventional and interventional cardiology. She was selected for the Zonal Round West Zone in Torrent Young Scholar Award for 2018. She has also been an author and co-author for various publications and research papers. So this was a little bit about our one and only Dr. Falguni Thanki, જે આપણી સાથે જોડાઈ ગયા છે લીલાવતી હોસ્પિટલમાંથી. અને actually તમે નહીં believe કરો, but she is right now at લીલાવતી હોસ્પિટલ અને ત્યાંથી એ લાઈવ થઈ ચૂક્યા છે આપણી સાથે. But ટાઈમનું ધ્યાન રાખીએ છીએ આપણે. એટલે now I would like to invite our one and only ભીષ્મ પિતામહ of surgery and આપણા જેમ હું always કહું છું સર્જનોના સર્જન Dr. Prakash Modha to share COVID na statistics, like COVID statistics at world level, India level, Gujarat level, and Rajkot level. So let me invite him. Over to you, Dr. Modha.
Yes, good evening viewers in India and good morning viewers in US. Today I will tell you the statistics of coronavirus in USA. It is 15,570 new cases and 161 new death. In UK, the cases are again rising. It is 22,644. But death is low, only 3 deaths. In India, cases are decreasing. It is 46,148 only. And death is under 1,000, is 907. In Australia, which I love, the only 29 new cases, and still so far there is no death.
Wow.
In total, Australia has got 907 deaths due to COVID, and that is since a long. So Australia is the country where the COVID is minimum. So now coming to Gujarat. The Gujarat also cases has come down only in 2 digits, 96 new cases of coronavirus and 3 deaths, only 3 deaths. So if we analyze the things center-wise, city-wise, Ahmedabad has got 21 new cases, Surat has got 14 new cases, Baroda has got 16 new cases, Rajkot has got only 9 new cases. So single digit again. And the most proud center is Bhavnagar. There are no new cases, 0 new cases. Jamnagar only 4 new cases. Junagadh 5 new cases. So all the cases of corona has come down. And so is to mucormycosis, and now again vaccination is increasing. People are queuing for vaccination, and I hope that they must get vaccine as early as possible so that we can fight the third wave of COVID if it comes very well. But let us pray that third wave should not come. Thank you, and hand over to Mirchita and Dr. Falguni.
There she is. So this is Dr.
Hello.
Falguni.
Yeah.
Welcome to the show, ma'am. How are you feeling?
Thank you so much. I'm glad I'm on this show and I'm seeing you through the show now because we know each other since long. But being on the show with you and Sir Prakash Modha sir, I'm also meeting you for the first time directly on the show. I've heard a lot of things about you, but couldn't meet you in person ever. But this is the good opportunity for me to be with you on the same platform.
Yes.
So
we
yeah, I'm
welcome
happy
you.
to. Thank you. I'm happy to be on the show.
I'm happy to have a lady cardiologist. I think she's the
Oh,
first lady cardiologist on the show. So it's an
yes.
honor.
Okay.
She
Yeah,
is my
it's a proud
sister
Good.
honor.
and a proud moment for me to have you on the show.
Thank you. Thank you so much.
And I'd invite Dr. Modha to say a couple words about Dr. Falguni.
See, I know Dr. Falguni through his father, who is my friend and 1 year senior to me at MP Shah Medical College, Jamnagar. So that is Dr. DP Thanki.
Mhm.
And we were almost 5 years together at Jamnagar. Then I went to Mumbai for my neurosurgery, and DP continued at Junagadh. So DP did not do any post graduation,
Yeah.
and he enjoyed life at Government Hospital Junagadh. And I wanted to do post graduation. I did not get admission in MP Shah Medical College in surgery. At that time, we were knowing only surgery, medicine, and gynae. That is the post graduation.
Hmm.
Other branch like ophthalmic, ENT, uh, they are all side branches, and nobody was preferring at that time. But I went to Mumbai, and Mumbai has opened the doors for me. You see, and I saw the world in a different way. And people also in Mumbai, they helped me a lot, and that's so is true for Falguni.
Same, same.
In Mumbai, people are very cooperative, helping nature, and if you are doing well, they will always support you. So I
Definitely. It's true.
salute the doctors of Mumbai and my teacher, Professor Ramani, who has taught me this thing. So Mumbai is Mumbai, where you can get education of all part of life, not
Definitely.
only medicine,
Absolutely. Absolutely.
but for how to work, how to behave, how to highlight yourself. Things are being taught in Mumbai. I
Yeah.
think Mumbai is the only center where you can get all this sort of experience. Otherwise, leg pulling, this pulling, that pulling is there. But Mumbai is a very good center. If though someone is deserving, the sky is the limit.
Yeah,
So with
absolutely
very much,
true.
I pray God that our Falguni should go up and up, grow very well,
Thank
and
you.
solve the cardiology patients.
Thank
Yeah,
you
Thank
so
you,
much.
one,
Falguni. Thank you,
Thank
Mirchita.
you.
Let us
yeah,
start our show by
yes. Hmm.
inviting our Falguni to tell us something about the cardiology.
Yes.
And
Yeah.
for the common people also, it is very helpful
Yeah,
that
definitely.
when to go, what to, where to do, what to do, that she will guide us.
Sure.
So
Thank you.
thank you, Dr. Moda. That was very sweet. And the first question I have for the show and Dr. Falguni and all of you is, what are the types of cardiac patients you have observed in COVID era?
Oh, all type of cardiac patients. There is nothing that we have not seen in COVID era. Of course, we are seeing certain amount of patient in more in number rather than the routine cardiac patient. But still, with COVID, without COVID, the number of cardiac patient, the variety of cardiac patient, they have not changed. But of course, with COVID infection, there are increase in the number of cardiac comorbidities. Those who didn't have any cardiac thing in their lives ever, they are now presenting with some or other cardiac thing, because COVID is a disease which it affects all part of body. So heart is no bar for that particular thing. So heart is also getting affected at various level, and we are getting all the variety of patient whom COVID has caused the damage to heart in one or other way. So starting from heart attack or myocarditis or cardiac arrhythmias, or you can say pulmonary thromboembolism. These are the medical terminology, but we are seeing those kind of patient in and out because of the COVID. So COVID affects those who already have cardiac issues. Along with that, COVID also affects those who don't have any cardiac issues in the past, but now because of the COVID infection, they are getting it. So yeah, all the varieties of patient.
Thank you, Dr. Falguni. So when we have so many patients, I know COVID is very stubborn. It will like, હું મારું શું કહેવાય પ્રિન્ટ ફૂટપ્રિન્ટ તો છોડીને જ જઈશ. જે કરવું એ
Yeah,
કરો, કા હાર્ટમાં કા બ્રેઇનમાં, તમારા એકો એક બોડીના ખૂણામાં હું તમને ડેમેજ કરીને જઈશ.
yeah,
So
true.
tell us, what is the impact of COVID in cardiac patients in general?
Yeah, so cardiac patients, it's a broad term, like which kind of cardiac problem you have. You can have
Hmm.
blockages in the coronary, and because of that, you are so called cardiac patient. You
Hmm.
might be having normal coronary arteries, but your cardiac pumping function has gone down, and you are
Mm-hmm.
suffering from that particular disease called DCM, dilated cardiomyopathy, which is very much common in diabetic patient. And diabetes, like in India, you have every 3 or 4 patient, one patient will be diabetic. So that kind of patients also very common. There are a lot of other patients whose cardiac coronary arteries are normal, pumping function is more or less okay, but they have some pacemaker implantation in their body because of XYZ reason. There are many valvular heart disease which is prevalent in our India, rheumatic heart disease. So they have sometimes damaged valve in their body, they have sometimes implanted valve in their bodies. So this kind of people, group of people, to name few, that we call them as a cardiac patients. COVID affects all of them at one or any other point. See, COVID is like an inflammatory state. It releases a lot of cytokines in the body, and that causes a lot of inflammation in the body. So heart is also one of the organ which gets inflammatory changes. And because of those inflammatory changes, there are chances that heart's muscle get damaged, and because of that patient will be having myocarditis, and that myocarditis will lead to decrease the pumping function of the heart. So already the patient who is having cardiac condition, on top of it, if his ejection fraction goes down, the pumping of heart goes down, definitely patient will be having signs and symptoms exaggeration. Along with that, patient who has stent implantation in their heart because of the heart attack in the past, or coronary artery blockages, unstable angina and stuff, and if they are getting COVID, so there are chances that patient with COVID will be having some mismatch in the, supply and demand supply mismatch that we call in cardiology, that the heart is not getting proper blood supply as compared to the demand which it should have. So in that case, they will get again recurrence of heart attack. Already they had heart attack
Oh.
in the past. For that, they have undergone stent formation, a stent, this thing, and on top of it, they will get again heart attack. So this, and then COVID does lot of electrolyte imbalance in the body.
Hmm.
Because of the electrolyte imbalance, sometimes it can happen that heart's rhythm can get go haywire in patient who are already heart patient.
Hmm.
So
Hmm.
that is also one way of presentation, that heart patient coming up with the cardiac arrhythmias. The rhythm of the heart is total abnormal. Top of it, there are valvular heart disease patient where you can get the infection over the valve. If the COVID patient gets lot of other infection, being long term on ventilatory support, they will be having lot of other bloodstream infection which can go to the valve which are implanted, and that can get affected, that can lead to infective endocarditis of heart valve, and that also lead to problems for the patient. So in a one way or other, there are a lot of mechanisms which are involved, but yes, those who have some cardiac comorbidities in the past, they have to be more cautious as compared to the normal person who is getting COVID.
All right. Thank you, Dr. Falguni. Dr. Modha, any comments?
No, no comments. Absolutely correct. Whatever she said.
Alrighty. So next question is long-term side effects of COVID in this whatever cardiac
Cardiac
patients you
patients.
told. Yeah.
See, long term, as such, cardiac patient or non cardiac patient, if patient's heart got affected through COVID, suppose patient is having history of cardiac illness, now patient has got heart attack. So he has to undergo whatever treatment for heart attack is, right? So either he will receive the thrombolytic therapy for opening up the blocked vessel, or he has to undergo angioplasty to put the stent and open up the vessel. So then he will be ultimately on many blood thinners, many other medication for lifelong.
Hmm.
And unfortunately, if patient's heart got damaged in that particular time limit by which he gets the treatment, and if his ejection fraction, that is the pumping function of heart, goes down, then it will be a lifelong thing. If it has come down to 20% or 25%, it is difficult for normal person to lead a normal lifestyle until and unless he is on particular medications. So it's like you can see as a long term damage. Or apart from heart attack, there are other disease, like patient can get this thing, pulmonary embolism. So that is
Hmm.
also one of the reason where the pulmonary artery gets lot of clot formation. For that we have to give blood thinner injection. Patient has to take oral anticoagulant for quite some time. But it can also sometimes affect the heart. The heart function can go down. That is mainly right side heart dysfunction. So that also lead to a morbid condition for which patient has to be on medicine for lifelong. If overall myocarditis happens, that also leads to decrease in the pumping function again, and that also leads to this kind of damage. Sometimes because of the low ejection fraction, like 20%, 15%, patient may require some implantation of the device, which is normally patient wouldn't have required if COVID has not affected those areas of heart.
Hmm.
So, yeah, if heart is affected in this kind of ways, then patient will be on lifelong medication and patient will be having lifelong comorbid condition.
Already? Yes, Dr. Modha. One second.
I want to ask
Mhm.
you, suppose if you do angiography in a normal heart attack patient and you do angiography in a COVID heart attack patient, do you get is there any some difference in the caliber of the vessels and length of the block and everything?
Nothing much. It's the acute attack. When we call it acute myocardial infarction, most of the time it is sometimes it is erosion of the plaque which has led to formation of the thrombus and which has blocked the artery 100%, and that's why we get attack. The other possibilities, patient is already having some cholesterol plaque deposition, 60, 70, 80% blockages. On top of it, some insult here and there that will clot the other remaining part of the artery, and that will lead to heart attack. So in acute attack, we see both kind of thing. Normal patients. And when we talk about COVID heart attack, most of the time it is like clot formation rather than having underlying coronary artery disease. Most of the patient will be having frank clot. Some little bit plaque is there which has got eroded, and there is a thrombus formation which is blocking artery 100%, and the presentation will be like that. Length of the blockages we cannot comment upon, it differs person to person. If person is already diabetic, if person is already having other risk factors for having cardiac illness, of course they will be having long segment atherosclerotic plaque on top of what the clot must have formed. So it varies. Sometimes it may be long, sometimes it's a small segment lesion. But yes, clot formation is the commonest thing which we encounter in both the patients, and that's why patient gets heart attack.
Yeah, thank you. Thank you.
Thank you, Dr. Falguni. The next question I have is very interesting actually. It talks about all different kinds of surgeries.
Yeah.
When does a patient need angiogram versus angioplasty versus stent versus bypass? એટલે આપણે સાંભળતા હોય નહીં કે કોકે એન્જિયોગ્રામ કરાવ્યો ને સ્ટેન્ટ મુકાયો, બટ actually ક્યારે જરૂર હોય છે, કેમ જરૂર હોય છે? Can you please explain all four in brief એના pros cons
Yeah.
અને કઈ procedure ક્યારે કરવી અને results અને basic
Yeah.
guidelines?
So yeah, it's a good thing that a lot of people, most of people, they don't have any idea what exactly the angiography and plasty is and what exactly the bypass surgery is. Sometimes they don't even know that who does what. I mean, if person is a cardiologist, okay, so you do. I get a lot of time this kind of questions that okay, you do bypass surgery, no, you do open heart surgery, you are a cardiac surgeon. So I have to
Hmm.
tell that I am a cardiologist. Cardiac surgeon is a different thing. So
Huh.
we are physician who are doing cardiology practice. So we deal with non-invasive. It's not non-invasive, but we don't open the heart. We are not surgeons. We do procedures percutaneously. Percutaneously means we puncture the arteries and we do our procedure through that route. While
Hmm.
cardiac surgeons opens the heart with the midline incision, they deal with the heart and they deal with the bypass surgery. So
Hmm.
what cardiac surgeon does is bypass surgery and they bypass the blockages of the heart. And what we do, we put stents through the peripheral vessels into the heart arteries, that is coronary arteries. So yeah, angiogram is required whenever patient is having any heart attack. So that
Hmm.
is first and foremost thing when we do ask patient ki you will require angiography when patient suffers for acute heart attack.
Hmm.
Acute heart attack, okay, that is one condition. Other condition is unstable angina. Sometimes patient may not be having typical changes of myocardial infarction, that is acute heart attack, but patient will come to you with history of exertional angina. That if I'm sitting, I'm okay, but when I climb the stair, when I'm walking at a faster pace, or I'm doing some strenuous exercise, I get chest discomfort, then I have to sit, and then my heart pain or chest pain will go off. So that is the indication for angiogram,
Hmm.
thinking that the patient will be having some blockages in the heart and you have to deal with those blockages.
Hmm. Hmm.
Then if patient is having any ECG changes without any symptoms, especially when patient is diabetic, because diabetic can lead to silent heart attack also. So
Oh.
those kind of patient also can undergo angiography. Apart from that, nowadays people are health conscious, so
Huh.
after certain age they would like to go for those health checkup schemes at various hospitals. So
Hmm.
that includes ECG, 2D echocardiography, and that includes exercise stress test, that is treadmill test. So sometimes we get patients with that stress test positivity also, that they don't have any other symptom, just because they've gone for routine health checkup, they walked on the treadmill, and after certain minutes of treadmill exercise, their ECG started showing some changes. They developed some symptoms. Once the exercise was stopped, they were all right. But then this kind of positive stress test ask for angiography, of course, because these are the tests which will prevent the disaster.
Hmm.
If you ask health checkup scheme or health checkup thing this intermittently after a certain age, it will help you only, that
Yeah.
this is like you can pick up certain things beforehand only, rather than you getting into myocardial infarction, acute heart attack condition, which is an emergency situation. You can electively ask for angiography and see whatever blockages are there, and if anything is to be done for those blockages, or only medical management is okay for those kind of blockages. So that is
Um.
angiogram.
One. Sorry to interrupt, but your mask is interfering with the
Oh,
this thing.
sorry,
Yeah.
sorry.
So it keeps on. Yeah. I
Yeah,
think
sorry.
if you can just remove it or just that would be much better.
It will be just a minute.
Yes. So, guys, we were a lot of people asked me what is all this angiography and plasty
Yeah.
and stand.
So,
So, yes, go
yeah,
ahead.
so I
Yeah,
have
perfect.
some few pictures also. So before I discuss about angioplasty and stent, I think better we go through those pictures, and then I can talk about that in a better way, that people will be getting some idea ki what is angiography, how we do it, and what is the stenting and why we are doing it. So being cardiologists, we do
Mm-hmm.
angiography, angioplasty, and we put the stent. The
Huh.
putting up the stent, the procedure is known as angioplasty.
Okay.
And so we can just see how we do it and where we do it, and
Mm-hmm.
then
Yeah.
so
Yeah, yeah.
we do this procedure called angiogram or angiography in the cath lab. So cath lab
Mm-hmm.
is a place where there is a X-ray machine. So what we ask, X-ray chest. Sometimes we have cough and cold and all. So we get ourselves X-ray chest done or other X-rays done. The same way, this is the machine. We call it a C arm. The arm is like
Mm-hmm.
X-ray machine. It gives us X-ray, and we have one. If you can zoom in and show it, that in front of that there will be a monitor on
Yeah.
which we will be seeing continuous X-ray. When we are just compressing the fluoro on mode, we will be seeing the continuous X-ray wherever we put that film on. So that CM patient will be lying on table, and that CM machine will rotate around the patient, so that
Mm-hmm.
we can take pictures of heart from various points. Whenever we are injecting dye into the patient's coronary arteries, we just move that C arm, technician will do that, and that pictures, whatever live pictures, contracting, beating heart pictures, and the coronary artery pictures, we will be seeing on the monitor shown there. And those picture will lead us and guide us that how many blockages are there, where we have to put the stent, how to go about it. So it is continuous X-ray exposure. So for that we need to wear lead apron and stuff, and then only we can go on with the procedure. So that is the cath lab. Coming to the angiogram, some people they say that How do you do that?
Hmm.
So we have many access, like where arteries are, we puncture those arteries, and we, through that arteries, we pass the catheter, we reach the patient's heart from where the heart artery arises, and through that catheter we enter into the coronary arteries and see that what's going on there. So we have many puncture arteries available. So most common thing, the starting point was to puncture the arteries in the groin, any side, left side or right side. We have those arteries in the groin which we can puncture, and through that arterial route we can enter into the heart. And there is other way, the puncturing the artery of the upper limb, that is radial artery. So in the hand also, so nowadays people talk that એ લોકોએ હાથમાંથી સ્ટેન્ટ મૂક્યો, પગમાંથી નથી મૂક્યો. So that is the difference, હાથમાંથી કે પગમાંથી, which artery you select, through that artery you go in and put the stent. So this is the radial artery you are showing, that the hand artery we puncture, we put the sheath in, and through
Mhm.
that we enter the heart with one catheter. So we have many hardwares in the cardiology which we use. So these are the guiding and diagnostic catheters. They have typical shape to engage into the particular coronary arteries. So wherever, whichever artery we have punctured, either through leg or through hand, we
Hmm.
insert this catheter through artery that will reach up to the heart, where the
Mhm.
aorta, that is the આપણે કહીએ ને મહાધમની આર્ટરી, એટલે જે મેઇન આર્ટરી છે એ ઓરિજિન થતી હોય ત્યાં સુધી એ કેથેટર પહોંચે. અને that artery itself has the origin of the coronary arteries. Coronary arteries means the artery which supplies heart. હાર્ટને જે બ્લડ પૂરું પાડે એ આર્ટરીને કોરોનરી આર્ટરી કહેવાય. એટલે આપણે જ્યારે એવું કહીએ કે હાર્ટ એટેક આવ્યો છે, તો
Hmm.
હાર્ટ એટેક શું કરવા આવે કે હાર્ટને પોતાને પમ્પિંગ કરવા માટે, પોતાનું કામ ચાલુ રાખવા માટે, ધબકવા માટે હાર્ટને પોતાને બ્લડ સપ્લાયની જરૂર પડે. તો એ બ્લડ સપ્લાય પૂરી પાડતી જે આર્ટરી હોય એને કોરોનરી આર્ટરી કહેવાય. અને
Hmm.
જ્યારે કોરોનરી આર્ટરીમાં બ્લોકેજીસ થાય ત્યારે પેશન્ટને હાર્ટ એટેક આવે. So we have to reach to that coronary artery in particular which is blocked. So these
Hmm.
are the catheters which we take up to the aorta and we engage them. See, this is the last
Yeah.
diagram you showed, na?
Yeah.
So
Yeah. This one.
no, next, the small heart and aorta wala. Next,
Okay. Huh.
next. This you can enlarge, or there was one next.
This.
This one, yeah. So this is the aorta. That is the tip of our catheter, which is just sitting on the origin of the coronary artery. So from leg or from hand, wherever we are puncturing the artery, this catheter is long enough to reach up to this aorta. And in aorta, we, under guidance of X-ray and fluoroscopy, we adjust a catheter that way that it sits on the origin of one particular coronary artery, and through that we inject the dye, that is a contrast medium which opacifies the coronary artery on X-ray. So when we take a picture, we see black dye going smoothly into the arteries if arteries are totally normal and without any blockages. If they have blockages, then we will see the feeling defect in that particular, so that part of artery will not opacify with the dye. So that means there is some blockages which are going on, or sometimes it is narrowed down. So you can see just thin string like picture on the coronary angiogram, and you can come to know that, yeah, this is the site where the block is, and this is the site where you need to put the stent. So this is the way we enter the coronary artery, through the catheter. Next.
Uh. So next question, or we wanna go back?
So that you can say continue the picture so that I can
Yeah.
discuss on that coronary stenting only, because
Yes. Yes.
ultimately what
Yes.
we were discussing is what is the difference between angiography, plasty, and bypass,
Yes.
and when you have to select that. So
Yes. Yes. So next is
so
this.
no, next is this. So this is what we see. This is just to show. This is not we see on the fluoroscopy image. This is just a theoretical, practical explanation that if this is the artery, you can see the yellowish part which is totally narrowed down and blocked. So what
Mm-hmm.
we do is we enter the coronary artery with one wire over the balloon, and then we dilate the balloon from the outside. So that balloon will crush open the arterial blockages, whatever is there inside. Most of the time it is atherosclerotic plaque, but sometimes in elderly patient it is calcified plaque also. So we have to just push and dilate the balloon, and after the balloon dilatation you can see the artery will be opened up. But our arteries are elastic
Hmm.
like એકવાર તમે ખેંચો એને મૂકો એટલે પાછું એની જગ્યાએ આવી જાય. So
Oh.
these arteries are elastic, so once you do balloon dilatation, for some time being the artery will be open nicely, perfectly feeling and all. But
Hmm.
because of this elasticity there are chances that it will recoil, like it will again go back to the condition which it already was in. So to prevent that recoil we put the stent. So in earlier days when the stent were not invented, at that point of time people used to do this kind of balloon dilatation procedure. So
Hmm.
whenever they encounter such kind of blockages, they will go in with the balloon, they dilate it and then they leave it. But the
Hmm.
results were and outcomes were not that favorable, because again as says it will recoil. Now the after invention of stent next, yeah, so this is the
Hmm.
stent. So
Hmm.
after invention of stent you can see that once the balloon dilatation is done, we go in with the stent is also over the balloon, so we dilate the balloon so that way the stent gets released and it will
Hmm.
stuck to the artery, and then we take the balloon and assembly out, and then stent will prevent that recoiling which used to happen with the simple balloon dilatation, and stent will remain in situ for years and years. That cannot be taken out once it is put. So that will keep the artery open, and then patient is free of any blockages or any chest pain or any sort of complaint once the stent is put and arteries have been opened up. So this is the angioplasty. You can see the stent which is dilated over the balloon. You can see the picture that once it is narrowed down, it is a small stent. With this kind
Hmm.
of diameter, we go in, and once we
Hmm.
reach into the artery, we dilate the balloon. So this
Hmm.
stent gets distended, and then it will be stucking into the coronary vessel, and then we take the wire and balloon assembly out. And if you can
So
see how
how it's gonna look inside your heart? The dilated one or this one? The second one.
dilated one, it will be
Dilated one.
always dilate one. This is
Okay.
narrowed down just because we have to
Just.
take it in the small diameter vessels, so it's
Hmm.
just compressed and taken in, and then we with the help of balloon we just put it in.
Okay.
Yes, and there are various size and
Size.
types
Yeah.
and
That was the
diameter of,
question.
yeah,
Yeah.
so see if you compare, it is on the tip
With
of the
the
finger. So
God. So
length will
small.
vary, yeah, so small because our coronary arteries are so small, no, they are in
Uh-huh.
mm's, millimeters.
Oh
So
my God.
coronary, if you see the left main coronary artery, that maximum diameter will be 4 to 5 mm.
Oh.
So it's not full centimeter even. So and it has again branches in which we go, so 2.5 mm, 3 mm, 3.5 mm, these are the diameters we deal with. So if you
Oh.
see the stent diameter would be 3 mm, 3.5 mm and stuff like that. And length of course depending upon the extent of lesion, how much longer the disease is inside the coronary, we decide. So it may be 2.5 into 10 wala stent, or it may be 3 into 48 wala stent also. It all depends on the length. So that we calculate after doing angiography on the
Huh.
fluoroscopy, and then we see that which kind of stent will be required for this particular patient. It varies with patient to patient.
But all patients they don't need stent, right? Stent is like extremely blocked, right? When
Yeah, so
correct?
usually, so when we do angiography, we have to decide the percentage of the blockages. So if it
Blockage.
is 70% or more, then only we kind of stent it. Lesion which are just 40-50% blockages need not to be evaluated further, just to keep on medical management. Of course we have to take follow-ups, we have to keep that patient under loop that yeah, this patient can get into 70-80% artery blockages in future if he is not compliant with the medication, or if he is not regular in the lifestyle management and stuff like that. So we ask them to closely monitor their system by doing echo regularly, by taking ECG, by doing stress test regularly. And if any point of time we feel that this lesion must have progressed, then we call them for angiography and check whether it has progressed further or not and requires stenting or not. But yes, of course, it is the first thing that not all blockages require stenting. That is for sure.
So this is the image, I think, for
Yeah, so
normal.
this is the normal coronary angio, which looks like this. So when we inject the dye through the catheter I showed, this is the X-ray kind of picture, and the thread-like vessel which you see. These are the ossified coronary arteries, right side and left side, and this is a normal coronary angiograph picture. So when we inject and we see picture like this, that means the coronaries are normal, and this person doesn't have anything in the heart. So if at all he is getting chest pain, that may be because of the non-cardiac reason most of the time. But when there is a narrowing down, patient is getting chest pain, you will see the angiography in a different way. So you have that video, I think, pre-angiography and
Yes, but before going that, I want to understand where in this picture you are inserting inside the aorta.
inside the aorta. Yeah,
Aorta.
inside the aorta, just above the aortic valve in heart, you have origin of coronary arteries. So we have
Oh.
basically two coronary arteries.
Mm-hmm.
One is right sided and one is left sided. So right sided is called right coronary artery. We use short form like RCA. And the
Mm-hmm.
left side is left main coronary artery, which divides into two arteries. One is left anterior descending artery, and the other is left circumflex artery. So we call it LAD and LCX. So when sometimes patient may tell you or they કે ડાબી બાજુ stent મૂક્યો છે ને જમણી
Ah,
બાજુ stent મૂક્યો છે. So
yes.
that is the thing. So if we deal with right RCA, then it is right sided stent, and otherwise left sided stent. So main three vessels, one is left main, which divides into LAD, LCX, and this side RCA. So total three vessels. Of course, they have their own branches. That
Mm-hmm.
is in detail. We do stent
Yeah,
those small branches also, but these are
huh,
the three vessels where
major.
we discuss about heart attack. So it is related to any of this artery where patient can get heart attack.
Already, this was excellent. And let me ask Dr. Modha. Any comments, Dr.
Yeah,
Modha?
Falguni, it was
Yeah,
excellent explanation. But for my curiosity,
yeah,
see, we do carotid endarterectomy. We do open. So we remove the plaque of that carotid artery. But
vessel.
is it possible that if you can introduce a device which will suck the block which is
Yeah,
there in the
we
coronary
have that.
artery?
Yeah, we have that. That is called thromboster. So particularly when we do acute myocardial infarction, acute heart attack wala patient, we assume that most of the time it is thrombotic lesion, that is acute clot formation. So before putting stent, we make sure that whatever clot we can suck it out, we try and do that. So there is a, device called thromboster, which we go in with that. There is a negative suction through which we take out all the blood and whatever clotty material is there, and then we go in and put the stent. So it always gives us a better result in acute condition.
Clot is okay, but I am
Yeah.
asking about the plaque. Suppose
No,
plaque
plaque.
is there.
No, plaque is there.
You
We
just
have.
dilate it or you
Yeah, we
that
just
you
dilate it.
dig it out and suck it.
Yeah. So there is a different plaque variety. So when there is a calcium deposition, arteries are too much calcified that your wire hardly goes in. Forget about taking balloon in or stenting in. So you have to first able to put the balloon in. If it is too narrow and it is too hard because of calcium, we have one machine called rotablator. So we take, it is kind of drill. આપણે ગુજરાતીમાં એને
Yeah,
શારડી કહીએ ને, it's like
yeah.
1.25 mm, 1.5 mm, 1.75 mm diameter no burr હોય છે, which is tip is diamond. So that is a sort of diamond cutter. We take the rota in, we do that drilling thing, so that drill out all the calcium, small particle which will go into the bloodstream and it get excreted. And after clearing up the path, we then enter with the balloon and then do further balloon dilatation, and then we put the stent. In fact, nowadays we have special kind of balloon also, which are cutting balloons. So they have some sharp edges over them. So when we dilate it, those sharp edges can cut the lesion further and make a room for the stent to be implanted. So we have a
Very
lot
good,
of
very good.
hardwares with which we can, deliver the stent system.
Very nice, very good.
Very nice. Yeah. Excellent. મને એવું કે ખાલી
Yeah.
ડેન્ટિસ્ટ જ ડ્રિલ કરે. Now I'm Now
The
I'm
drill
No,
most
no.
realizing
people
Drill
करे.
is everywhere. Drill
everywhere
is
Drill is
also,
everywhere.
everywhere.
Yeah.
Ortho करे, neuro
also
करे. Spine માં
But
everywhere.
જે બધું drill.
our may be the smallest one. Ours may be the
Smallest.
Yeah.
smallest one because we are really drilling in coronary vessels. So it is the
Yeah.
smallest drill available.
Smallest, and that might be a diamond one.
Yeah, the
So
diamond one, of course.
Already. So only one question I have. Which procedure has given the best results? Okay, it depends on the type of
See, yeah.
blockage.
So coming to that again, bypass.
Huh.
Who
Huh.
should go for bypass and who should go for angioplasty?
Hmm.
So again, you have to see the patient as a whole. Like if patient is too young, nowadays we are seeing very young people getting heart attack, 30,
Oh.
35, stress, smoking. These are the risk factor. Even diabetes also in younger age group. But
Mm-hmm.
then if you see just one single vessel block without any much other vessel involvement, patient is too young, then he should definitely undergo angioplasty because it is less. I mean, you don't need to stay in hospital for longer period of time.
Hmm.
You are not taking stress of opening your chest and being comorbid for longer period of time. The recovery is faster. Patient can be mobilized on very second day of angioplasty. So younger people, yeah, they require this kind of procedure. Certain nowadays we put more number of stents. Even though there are many blockages, we put 4, 5, 6 stents and we can get away with it. So nowadays it's not that if you have 5, 6 blockages you have to ask for bypass only. You can always
Hmm.
ask for stenting, provided the anatomy of your vessel is favorable. Sometimes there are blockages at the bifurcation of the vessel, so you have to deal those bifurcations standing in a particular manner. If the cardiologist is skillful enough to deal with those bifurcation, he can always put the stent and get rid of block without asking patient to go for bypass. But there are many studies which are coming up that diabetic patient with very bad heart arteries, they have bypass result better than the stent result.
Hmm.
But they have to have those many blockages. If diabetic patient having single or two blockages, always stent is preferred over the bypass surgery.
Hmm. Hmm.
And as I told you, if patient is young enough, 40, 50 માં હોય અને 40, 50 વર્ષે bypass થઈ જાય, તો bypass is not forever. Bypass can also get closed. So after 10, 15 years down the line, if patient's bypass gets closed, then what will happen? So you have to keep those things in mind, that if you are giving option of stent at the moment, after 15, 20 years, if he develops more blockages and if he requires bypass, he is always having one option available to him. Because if એકવાર bypass થઈ ગયું પછી બીજી વાર bypass કરવું એ વધારે risky થઈ જાય rather than just first time bypass માટે જવું હોય તો. So there
And
are a lot of things coming into the play that you have to take a call whether this patient requires angioplasty or this patient requires bypass.
so bypass is, I think, the last option available. And what
Definitely.
exactly happens in layman terms when you say you have done both?
Bypass. Yeah, so in bypass, the surgeon will open the chest. So they
Mm-hmm.
have many vessels which are blocked. So they will bypass and they will take the graft from the our own arteries. So there are certain veins which can be cut from the body part, and they
Hmm.
will make an artery and they will attach that artery from the aorta to that particular diseased artery in the distal end, so that bypassing the blockages that way. So that graft can be arterial graft, that can be venous graft. They take it either from the leg veins or they can take it from the radial artery, or they can take it from the internal mammary artery which is there on the chest side. So
Hmm.
any of the arteries they use, they take it, they attach with the aorta, they attach with the distal most part after the blockages. So that way the distal part will be getting blood supply, and through that distal part artery, heart smaller capillaries will be filled through that artery. So that is the bypass. But as I said, it is a big procedure.
Big
It's
procedure.
open heart surgery. Patient will
Uh-huh.
require ventilator. Patient will require anesthesia. So there are a lot of other complication also which can occur with the bypass. I'm not favoring angioplasty or bypass. Again, I
Hmm.
said you have to select the patient. You
Select.
have to put in the category in which patient is fitting, and then you have to take a call whether patient requires stenting or patient should go for bypass surgery.
Excellent, excellent, Dr. Falguni. This was very, very nice. I think Dr.
Good.
Modha is also like, yes.
Yes, yes. Very good. Very good.
So I think we have covered most of the no,
Cardiology point.
કાર્ડિયોલોજી પાર્ટ એઝ વેલ વિથ ધીસ અમેઝિંગ ક્વેશ્ચન રાઈટ કે બધું એક સાથે જ
Yeah.
આવી ગયું એક જ ક્વેશ્ચનમાં. But
Yeah.
the next question I have is, see, when we talk about surgeries, the first question that people get is, બેન ડોક્ટર તમે એ કહો કે આ સેફ છે કે નહીં, આ કરાવવું કે નહીં. એટલે that is my next question, which is it safe to undergo all this procedure in COVID patients?
Yeah, COVID itself is a problem for doctors. Rather, if a patient is COVID positive having heart attack, then patient will require angiography for sure. So in that case, patient will not face any other side effect apart from having some plus minus heart condition like cardiac rhythm may be unstable, maybe BP will be fluctuating. But then the care should be on doctor's side and medical personnel side, that they have to take care that they don't get infected through that positive patients. Those who are negative but in this COVID era they require angioplasty or angiography, then it's a difficult thing for them. We are seeing patient getting scared to come at hospital even for
Yes.
getting evaluated. So that again depend on your hospital protocol. So as a hospital or as an institute or as a private hospital person, you have to take care of patient safety first. So if you follow routine hygienic protocol in your hospital, we are doing lot of plasties day in day out. In COVID era also the cath is working. It's not that it has been shut forever or something like that, but we do take adequate precaution in form of the whenever patient is getting admitted, we make sure that patient's COVID report is negative. We make sure that sometimes when the COVID was at a peak, we make sure that we do HRCT chest of the patient just to see that patient is not having RT-PCR negative but CT positive COVID. And once patient is in the hospital, we as a doctor and other staff also, we take adequate precaution that wearing mask, having all the
But sorry to interrupt. The one question I have is, a lot of patients, they are okay to have the worst blockages and stay with whatever they have, right?
Yeah.
But they don't want to go to the hospital for any of this angiogram or angioplasty or stent, whatever. They don't want to do that. They are feeling that it is a risk. What if I catch COVID and die rather than the procedure? So that question I have, okay, what advice do you have for these kind of
I
patients?
would advise that I would advise that if it is elective procedure, okay, you can wait for a month or two till you are getting down on the number of COVID. It is not a mandatory thing to go right away. But if patient is having acute event, he should not at all neglect that, because we are seeing many MI complications later on. So sometimes it happens that patient is telling that મને તો 15 દિવસ પહેલા chest pain થયું હતું પણ આ કોવિડ ને લીધે અવાયું નહીં, હવે એકદમ શ્વાસ થઈ ગયો છે, હવે હું આવું છું. So already artery has got impacted, heart has got impacted, the pumping function has gone down. Now even if you do angiography or angioplasty, we don't know how much myocardial recovery will be. So patient will be in lifelong mess. So I would advise that patient should not neglect any of the acute symptoms. If they need to come to hospital with all due precautions, they have to consult the doctor and they have to take the advice, and whether to undergo angiography or not, let the doctor take a call over that. But at least he can get some medication which can give him temporary relief. So they should not neglect at all. They should consult somebody who can guide them further what to do and how to go about it.
Thank you so much, Dr. Falguni. Next question. Yes, Dr. Modha.
Let me.
Yes. Dr. Modha, we can't hear you.
We can't hear you. Yeah.
Oh, once. Yes. Can you say again?
Now?
Yes,
Yeah.
better.
See, in a case of cerebral infarct, suppose middle cerebral artery is infarcted, if the patient reach within 3 to 6 hours, we can revert the stroke. So similar thing is there in the heart, that they should come within 3 to 6 hours to revert the block, or there is nothing time period like we have got in our neurosurgery or neuroendovascular surgery.
Correct. Dr. Falguni, are you there? Oh, I think her network got disconnected. She is actually from the hospital.
Yeah, hospital only.
Yeah.
એટલે
Hmm.
હાર્ટમાં પણ જો એવું હોય તો આપણે ખબર પડે. અમારે તમે 3 થી 6 કલાકમાં પહોંચી જાઓ તો
Hmm.
તમે તમારો પેરાલિસિસ રિવર્સ કરી શકીએ.
Oh. Okay.
યા એ
એટલે
મિડલ
ટાઈમ.
સેરેબ્રલ આર્ટરી લીધે હોય તો.
Hmm.
પણ નહીતર તો પછી વી આર હેલ્પલેસ. એટલે એવો કોઈ કાર્ડિયાકમાં રૂલ્સ છે હવે ચેસ્ટ પેન થયું કે તરત પહોંચી જાવ 3 કલાકની અંદર તો તમારું બધું સેફલી થઈ જાય?
Hmm. Hmm. I
So I
think
think
she.
Falguni, we have lost Falguni.
I'm trying to connect with her offline. પણ the next question I think હવે તમને પૂછું, which is આપણે continue કરીએ, હું એમને call કરું, which is, can patient be discharged after all these surgeries or it depends on the recovery time of the patient?
See, usually stenting, they discharge the patient either in the same day evening or next day. So it's a daycare procedure. Actually, stenting is a nowadays daycare procedure. Most of the patients are
Mm-hmm.
being discharged in the evening.
Uh-huh.
But sometimes suppose they have put 3-4 stent, then they do
Mm-hmm.
keep the patient for a day or so. Am I right, Falguni?
Sorry, because I have
Yeah.
some net issue. I don't know. I got disconnected in between. But
Yeah.
what I
So I will
understood.
tell you what she has asked is ask
Yeah.
which.
So the we discussed about all these great procedures, right? And a fear and when patient should approach. Time is the key, as Dr. Modha was saying. But the next question I have is, can a patient be discharged after all these surgeries? It totally depends on the recovery time. It depends on number of stents or any.
Yeah, I got it. So in usually when we do angioplasty procedure, and if
Hmm,
it is elective and planned procedure, so
hmm,
we don't require much of the hospital stay. Even if it is 2-3 stents or 4-5 stents, doesn't matter. Once
huh,
the patient is mobilized, so one day ICU stay, and third day we can third or fourth day at the max patient can be home.
hmm,
Once we are sure that patient can be mobilized well, then there is no need for more hospitalization. So in COVID era, that is also one of the advantage of angioplasty over bypass surgery, that the hospital stay is minimized. Like they can come for angiography plasty and within 3-4 days they can go back to home without getting infected with COVID or any other thing. Once patient is having bypass surgery, the stay, like hospital stay, ICU stay, will be 3-4-5 days depending upon the drainage and lot of other post-op things. Then they will be shifted to wards where they have to exercise and physiotherapy and lot of stuff. So minimum 10-12 days they have to
hmm,
be in hospital. So in COVID era, that is also having one edge over. So when we discuss about the option and we give patient option of bypass versus stenting, where both the
hmm.
things is possible, they will always choose the stenting over the
Stenting.
bypass surgery because of obvious reasons.
Yeah. Yes, Dr. Modha.
Yeah, Falguni, I wanted to ask you, in our neurosurgery, suppose patient has got a stroke, middle cerebral artery infarction. Patient comes within 3 hours or 3 to 6 hours even nowadays. So we can pull that clots out and patient will recover immediately and we can revert his hemiplegia. So is it something like that in the heart that patient should reach to you within 3 hours to 6 hours or something like that?
Yeah, so when we are talking about tertiary care hospital like ours, the primary that is we called as PAMI. So that is primary angioplasty in myocardial infarction. So when patient is having access to a tertiary care hospital where the cath lab is available, where the cardiologist is available, it is always preferred to reach in time within 120 minutes or so, so that we can just take patient in the cath lab and we just open up the artery before it gets damaged or heart gets damaged. So we have that time limit, of course. And sometimes we thrombolize the patient if patient is beyond that time limit, the heart, the pain is not that much, or depending upon the various ECG and other criteria, availability of cardiologist and all. So we give that blood thinner injection, and maybe we may wait for that blood thinner injection to work on patient's coronary artery, and then decide when to take patient for angiography. Sometimes patients are not having access to good hospitals. So the other option would be to give this thrombolytic injection in time, and then you shift the patient to a tertiary care hospital when the angioplasty is available, angiography is available, and then patient can get it done. So always time is important. As soon as possible, if you open up the culprit vessel, you can save the muscles to get damaged further, because ultimately it is going to create a scar over your heart, and the scar
Hmm.
can lead to a lot of other complications also. So yeah, the timing is important, but we never know when patient is coming, from how far it is coming. Nowadays in city side you face the traffic and other problems also. So as soon
Right.
as patient's arrival is there, we try and take him up for angiography just to see how the things are. And if it is not possible in those odd hours, or depending upon patient situation, we may do thrombolysis, and then on second or third day we may take him up for angiography.
Second thing I wanted to ask you that nowadays angioplasty is a daycare procedure. Suppose
Yeah,
patient comes in the
angiography is a
morning,
day-care procedure. Yes.
not plasty and stenting. Suppose you put a single stent, can you discharge the patient in the evening?
No, we would like to observe patient in ICU for a day. That is for sure, because angiography you can do in a daycare procedure. Patient comes in
That
the
is okay.
morning, but angioplasty is something that you have to be careful for next 24 to 48 hours, because stent is a metal object. It is some foreign body that you are inserting into your heart. So,
Hmm.
and you are creating a damage by balloon dilatation in the artery by putting stretch. So always there is some internal damage to the vessels endothelial lining, and our body's reaction to it will be thrombus formation. So we want to prevent those kind of thrombus formation, because one of the complication of stenting is that acute thrombosis and shutting down of the stent immediately,
Stent.
and then patient can get into the myocardial infarction because of stenting itself. So we don't want that. So we load patient with double anti platelet agents. We give anticoagulants like heparin and all during the procedure. And if we are putting larger stent, bigger stent, or we are giving more number of stent, or patient has come in the acute event, we may give anticoagulant injections for next 8 to 10, 12 hours. That
Wow.
is GP3 inhibitors and stuff. So type A lesion also we don't discharge on the same day. We would like to observe for at least 24 to 48 hours just to see that patient is doing good, the stent is not getting occluded. And of course we have injected the dye, which is again having some effect on kidneys. So we want to make sure that patient is hydrated well by IV fluid and all post procedure also, because the amount of dye we have used is large in quantity. Then patient will require adequate diuresis and just flushing out of kidney. So in any which ways, it is always better to keep patient in hospital for a day or two post plastic.
Okay, okay. Thank you, thank you.
Excellent. So I think we covered all the cardiac procedures, basic cardio,
Yeah,
and everything in this much time right today.
yeah,
But there are a couple videos I think about the coronary angiogram, right? About the
yeah,
normal versus abnormal. So Dr.
yeah.
Modha, shall we take it or
Yeah, take it fast so
take?
that
Okay, yeah.
we have crossed the time
Yes,
limit.
yes. I'd like to like quickly add this video, and she can talk about this coronary angiogram. Yeah.
Yeah, so we can see this arteries getting filled up, and there is right side. If you see, there is one string-like arteries. I cannot just
Hmm.
pinpoint it, but then if you compare the diameter of the upper wala artery with the artery down, there is a middle part of the artery. You can see there is a string-like appearance, which is a block. So next thing, what we did was, you can change the, we put
Yeah.
the stent in two of that artery, bifurcation wala artery, one the straight one, the other which is coming out of it. So this is the stent on the left side. If you see the radio opaque thing, the longer one, so
Yes.
that is 3 into 36 wala stent, which we can see, and then that stent is getting put. And then next,
Yeah. So the
the
next video is this
post
one.
post stent, if you see the arteries good opened up, the diameter is smooth, you can see. If you have noticed that string-like appearance which was there in the earlier part of angiography, now it is totally covered with the stent. And when this dyes goes off, if you can notice the stent also, we can see on fluoroscopic image the smaller part. So we put this two stent in the two artery which were
Oh
blocked.
wow. Yes. So I think this is what we have, right?
Yeah.
And what is oct imaging before stenting and
OCT,
after? Yeah,
OCT
oh, sorry,
imaging. Yeah.
OCT. Yeah.
So if you talk about the advance in the coronary angioplasty, we have a lot of things. As I told earlier, also we have rotabladders through which we cut the calcium. This is the OCT imaging. That is also one type of imaging, like you do X-ray, sonography in the body. This is the
Yes.
same one of the type of imaging. We insert the camera tube inside the coronary vessels from distal
Wow.
to proximal. We pull it back, and the side images are showing us that where is the calcium, what is the type of blockages, how lengthy the blockage is, like from where it's starting and where it is ending, what is the peculiarity of that particular block, where is thrombus or clot formation is there or not. Depending upon that, we decide which kind of stent we have to put, which length of stent we have to put.
Mm-hmm.
So, and then after putting stent also, we do this OCT imaging just to see that stent has been put in a proper manner, stent has been distended in a proper manner, there is no any dissection inside the stent, there is no any prolapse of tissue in the inside. So a lot of technical things involved, but
Yeah.
with this kind of imaging modalities, it is easier to deliver the best of the things to the patient, where the earlier ages it was not the case, like we do it blindly, randomly. It's not blindly, but you have very limited
Limited
access and
visibility.
limited views available to decide on your stent. Nowadays, because of the OCT, there are other images also through which you can IVUS, that is another image, through which you can image your arteries in a nicer way, and you can decide perfectly which kind of stent you have to put. So ultimately it is good for
Mhm.
patient and patient overall outcome.
All right. Thank you so much, Dr. Falguni. Any innovation or any case you want to talk about? Then that was my last question, but I think we have covered everything E
Lot
to
of
Z.
cardiology talk today. I mean,
Yeah.
cardiology is like innovations are daily happening, day in, day out. Just a recent experience, one of my uncle underwent replacement of the aortic valve percutaneous way. Like as a cardiologist, we only could do that. Earlier, the valve replacement was a big surgery, like open heart surgery. After certain age, if your valve gets narrowed down, it is has to be open. But in 70, 80 years of patient, you have a lot of other comorbid condition where to undergo the surgery like open heart surgery, it's always a risky procedure. But now this is the innovation that you take a big valve through your groin arteries into the heart, and you just put that valve in the place of aorta. The same way patient will be staying in ICU for 2 days, and third days gets mobilized, and fourth day patient will be going home. So just imagine valve surgery within 3-4 days of discharge. It's something which is really innovative. So we have started that at our place since last 5-6 years. I'm here
Uh,
and I'm seeing that kind of procedure. And recently, we did it for one of my uncles. So yeah, that is a good innovative thing that is coming up in cardiology, and a lot of other stuff also. So daily
See,
something or the other innovations are going on.
yes, Dr. Modha.
Falguni,
Yeah,
you talk about the aortic valve. Can
yeah.
you replace the mitral valve?
Yeah, they've started that way also. The trials are on in the Western countries. Hopefully, we will be getting it in our this thing soon. There are one or two centers in Mumbai also which were part of the trial, and they did replace the mitral valve percutaneous way, the same way like aortic valve. And if it is the positive trial, then it's a really good thing for patient also that they have
Yeah, yeah.
just 3-4 days of
It
hospital
will
stay.
change the life of the patient,
Yeah, yeah,
and
definitely. This TAVI
it
procedure
will give
also has
lots
changed a
of
lot of
money to
things.
the cardiologist.
Yeah. That is true.
Arey,
Yeah,
they in Leelavati, right? I can't ask her this question, but when she came to US, I was telling, oh, you met, this celebrity, you operated on that celebrity, and I was super, like, we were having that chat, right? And she was like, that's
Yeah,
normal, day in, day out for me. All
yeah.
the celebrities come here.
Yeah.
So money wise they don't have issue, I'm sure.
Yeah.
ના એમ નહીં, આમાં વધારે મળે ઓલા કરતા. બમ્બે એન્જિયોપ્લાસ્ટી કરતા આમાં વધારે મળે.
But it
Great.
requires lot of skill. It's not that
Yeah.
each and every cardiologist can
Extremely
do that.
highly skilled procedure.
It's a highly
And,
skilled procedure.
In the Mumbai,
Yeah.
how much it is costing? Tell me, aortic valve replacement.
The cost is an issue always.
કેટલી પણ એમ
35
તો
plus minimum.
કેટલું?
35. 35.
Oh my
Because
God.
35.
35 lakhs.
Yeah. Because the
Good.
valve itself is 23-24 lakhs. valve.
Oh.
So
Yeah.
there
So
are
10
Indian
lakhs
valves
goes to
available
physician,
nowadays.
cardiologist.
No. Now they have the Indian variety of valve available. So that is around 15 lakhs or so. But what we use here is a Medtronic. So that is Medtronic or any other St. Jude's and all.
Yeah.
But then Indian valve is also in the market now. They sell at a cheaper rate.
Yeah.
But if you see if patient is having really active life but is highest risk for operative procedure, then he should be offered this kind of percutaneous procedure if he can afford
Yeah,
it. There
yeah.
is no doubt about it.
Absolutely. Correct. Very good.
All right. This was such a nice talk. I had the
Yeah.
pleasure.
This is something new which I was not knowing. Valvular replacement I was not knowing. Rest of the things I was knowing.
ये मुंबई की असर है. That's what I would say.
That's why I love Mumbai till today.
Yeah. Me too.
She was like San Francisco is okay, but Mumbai is
Yeah.
Mumbai. She came
Mumbai
here.
is Mumbai.
Correct.
Yeah, I've been
Absolutely.
to
Till
US.
today I am telling the
Huh?
same thing. Mumbai is Mumbai.
Mumbai is Mumbai, definitely. There's something in Mumbai that no other city has.
Yeah.
So,
But
Rush,
anyway.
managing time, catching the train, it's a hell of a problem. But still people
yeah.
love Mumbai.
But still, we feel that Mumbai is Mumbai. Yeah, definitely.
Yeah. Mumbai
Some
is
kind of magic is there in Mumbai.
Yes, absolutely. Really, once you addicted to Mumbai life, you will not like any other part of the world.
Agreed.
All
It's my
right.
experience. You see,
હવે તમે એમ ના કહેતા કે તમને રાજકોટ નથી ગમતું.
મને સાંભળ. Actually, મારે બોમ્બે, I wanted to you switch off the broadcasting. Then I will.
Oh,
tell
okay,
you
okay.
the truth.
So guys, let's end the program. There is some personal story secrets that I'm going to
Yeah.
ask Dr. Modha about his Mumbai
Yeah.
journey. But I want to thank
Yeah.
Dr. Falguni and Dr. Modha for such an amazing show. And any comments, then please let us know the feedback. It is great to share this platform with both of you.
Same
Thank
here.
you.
Same
Thank
here.
you.
Thank you.
Thank you, everyone. Kale, Dr. Modha,
Yeah.
you can tell
Kale,
us.
આપણા most favorite doctor, Dr. Dekiwadia wants to present the varicose vein, and he will deliver his lecture, slide presentation videos for the common man. What are the causative factors? How they are treating varicose vein, and very easy way of treating varicose vein nowadays. So Dr. Dekiwadia will tell us in detail tomorrow. So tomorrow's is varicose vein. Then our people will go next. Administrative people will go
Live Gokul virtual tour કરાવવાના છે અમે.
Yeah, that
With
will be on
Mirchita.
Thursday. Yeah,
Yes.
53rd day. 53rd show.
53rd અમે કહીએ છીએ 50 કરવા તો હવે અમે 53 તો પહોંચી ગયા છે. Anyway, કાલે બધા જોડાઈ જાજો પ્લીઝ. And this was amazing. Questions તમે અમને કોમેન્ટમાં લખી શકો છો. અને please keep watching COVID awareness shows with Dr. Modha and one and only Mirchita. Bye bye everyone.
હવે આપણે we want to change this. COVID awareness is now over.
Let's talk about it કારણ કે હજુ બધા ડોક્ટર્સ ને આવું છે.
ભલે ને આવે, they will talk.
They want to talk about COVID also, right? So
Yeah.